Okay, thank you. I'm Sanjay Sarup. I work in Artemis Hospital, which is a corporate hospital in the National Capital Region of Delhi. So I'll be talking about skeletal surgery to improve gait today. And as we know, the cerebral palsy has spastic effects, and that increases the tone. It causes inhibition of muscle growth, resulting in a contracture. Ultimately, there is a deformity and lever arm dysfunction, and loss of function and loss of motor activity. So impairments in CP, you can broadly say that there are primary impairments which are basically spasticity, co-contraction, clonus, hyperexcitability, and released reflexes. And the bad effects are weakness, fatigue, loss of selective muscle control, poor balance, relative muscle imbalance in arms and legs, sensory impairment, and cognitive impairment. Due to effects of primary lesion, you get secondary effects. Basically, it results in a muscle contracture with the muscle being too short and too tight, and bone deformity occurs over time because of slow plasticity of bone. By that we mean that growth keeps on happening in the bone, the soft tissues do not stretch, and bone deformity results. Ultimately, it results in joint instability and lever arm dysfunction. The picture on this side is clearly showing you a very spastic iliopsoas muscle, increased anteversion of the femur, secondary dysplasia, ultimately subluxation and dislocation. And orthopedic surgery plays an important role in secondary impairments in cerebral palsy. Now, what are the goals in an ambulatory patient? One is you have to try to improve the gross motor function. You try to reduce the crouch. You want the feet forward and plantigrade. You want to optimize efficiency of gait and improve physical function. This is your wish list. So let's tackle femoral anteversion first, because it's very common to have femoral anteversion in cerebral palsy, and Novacek found about 50% cases there. What happens with increased internal rotation of the hip? There is the diagram to show you what happens. Increased anteversion causes the trochanter to move back. The lever arm is decreased for the hip abductor, which is already weak, and therefore you get a decreased coronal plane moment, arm of the hip abductor, and in order for the child to improve the efficiency of the abductor, they tend to internally rotate the hip so as to restore the abductor lever arm. As a result of that, the internal hip rotation causes in-toeing gait, and you can see that here, the knees pointing medially, feet pointing medially, weakened knee extensor because it's not in line with the line of gait, ankle plantar flexor weakness, varus knee strain, the gait becomes inefficient, and as you can see here, there is failure to clear the opposite foot, tripping and failure to clear the ground. You can see classically in this video. So the answer is a femoral derotation for internal hip rotation, and it's the primary procedure adopted to improve the in-toeing. Usually it is a part of single event multi-level surgery, and this gentleman, Akalau, produced a paper, and he showed that how increased femoral anteversion is different in cerebral palsy children. That means the effect of increased femoral anteversion is enhanced in cerebral palsy as opposed to normal kids. And he actually recommended that you should do a femoral derotation quite early in growth and not wait for the full lever arm dysfunction to develop. So, since femur has two ends and two metaphyses, so you have a proximal osteotomy which is done at a subtrochanteric level, and you have a distal osteotomy which is done at a supracondylar level. There are two schools of thought. Locked plate fixation is carried out. Some people like prone positioning in operating room, and usually people try to equalize, or we try to equalize the internal and external rotation, or we give slightly more external rotation. Here is this kid. He was a gross motor 1 with severe intorsion, and this is him pre-op, and this is him immediately post-op. Like, you take off the drapes, and you can see the dramatic change a derotation offers to these children. It changes everything for them. And this is not just a femoral derotation, this is a tibial, distal tibial derotation at the same time. So, two schools of thought, which is better? Proximal osteotomy, usually a younger child, and it can be combined with a varus derotation, with a varus of the hip, so to improve the containment. I'll show you some examples. It's a more common procedure, and Uni Narayanan recommended that you should make the osteotomy slightly more proximal to the lesser trochanter in order to relax the iliopsoas muscle. That is not our practice though. Distal femoral osteotomy, it is better suited to an older child who's over 8, and you can build various angulation correction or even a derotation at the knee level, less complications and quicker return to weight bearing, according to some authors. Here is an example. This is a child who has a subluxed hip, and he has undergone a varus width derotation in addition to a procedure on the pelvis in order to contain the hip. Here is another one, same thing, a little more elegant fixation, and this is a follow-up of 1.5 years. And similarly, an older child, gross motor 4 now, and this is a 3-year follow-up in which we have done a Bernese here and a derotation and a plate fixation there with some degree of varus built in. Now, does it improve gait? Most of the authors seem to think so. They say yes, internal hip rotation and in-toeing does improve, and various parameters of gait, they do improve. Internal and external rotation arc does improve. And Pirpiris thinks, he said that there were equal results with both proximal and distal femoral derotation osteotomy. However, there is a paper by Boyer et al., and he retrospectively analyzed the femoral derotation osteotomy. He says, yes, it is effective, but when he compared the results with closely matched controls, he found that 30% of the limbs remain in internal rotation in both controlled and the femoral derotation group in stance. So, what are the complications? If you operate early, you can get a recurrence in up to 1/3 of the patients. These are the complications which are typical to any osteotomy, apart from the AVN which develops in the proximal femur osteotomy. And some children maintain a postural internal hip rotation even after correction. This is what Mr. Miller says, and this is what Boyer said. And if you operate late, there is a compensatory tibial external rotation to deal with. So it's a little balance. If you operate early, you can have recurrence. If you operate late, you get more secondary deformities. And long-term effects of FDO, nobody is really sure, but it's subject of a clinical trial at the moment. Now, tibial torsion. This is the other rotational anomaly that you very frequently see. One effect is cosmetic, that means in-toeing and out-toeing, and functionally, yes, tripping, leg pain, poor endurance, and brace intolerance. But the same cycle of lever arm dysfunction comes in, foot malalignment in relation to the line of gait, then decreased effective extensor lever arm, decreased efficiency of muscle around the ankle and the knee, then decreased ability to impart power to the gait cycle, and decreased ability to control progress in the second rocker. So ultimately you get excessive dorsiflexion in stance, excessive knee and hip flexion, so you have a crouch to deal with. So pathological tibial torsion, non-operative treatment doesn't work, so you can't really brace it well. Surgical treatment is the only effective method to treat maltorsion. Most authorities will agree that minus 15 degrees intorsion or plus 30 degrees extorsion does need treatment. This is a kid whose feet look out quite straight. He has minimal spasticity, but when you kind of make the patella face forwards, the tibial torsion is revealed. So again, a tibia has two metaphyses, therefore two schools of thought. Some people like to do a proximal tibial derotation osteotomy, and the osteotomy is just below the tibial tubercle, but it has a high complication rate, and these complications can be quite devastating. So you can have a vascular injury, a foot drop, a compartment syndrome, so therefore a fasciotomy is always recommended. Distal tibial derotation osteotomy, it is done at the distal metaphysis, lower complication rate, has some skin dehiscence and deep infection, but it is recommended by many studies. Overall, if you look at the literature, complication rate is 0 to 35%, residual deformity 0 to 39%, with refracture and growth arrests also thrown in. However, Selber produced a very nice paper in 2005, and he looked at 91 distal osteotomies, and overall complications in a well-executed distal osteotomy is about 5%. He recommended a distal osteotomy, he recommended a plate fixation, he recommended an external fixator if the deformity is very large and needs gradual correction. Regarding fibular osteotomy, it's a bit controversial, but it may be required for more than 30 degrees of correction, and if the child is over 9 years of age. Now, there are two methods of fixation. You can use crossed K-wires, or you can use a plate. The crossed K-wire is low cost and quick, but there is loss of reduction in late valgus deformity, and above knee cast is required and mobilization is slow. Whereas plate fixation, it's exact in correction, there is no loss of fixation, below knee cast can be applied. Of course, there can be some delayed non-union, and second surgery is required for implant removal. What is our practice? We usually do it as a part of SEMLS. We use a distal supramalleolar osteotomy, and we use a fibular osteotomy if correction is over 30 degrees, or if the child is more than 9 years. And we usually use a small fragment plate. Now, this is one of the few instances where we have used a wire, and just to show you that there is a valgus alignment and overall healing is in valgus. So there is some substance in what most people say about cross K wires. Now I'll come to the foot because we are short of time. I have skipped a lot of stuff, but then 15 minutes. Natural history of foot deformity is poorly defined. Primarily, you have to look at three kinds of deformities. One is equinus, equinocaovarus, equinoplanovalgus. These are secondary, ankle valgus and hallux valgus. However, because equinus is mostly soft tissue surgery, we will not touch upon that. We will touch on these two and the hallux valgus. Now here we are. Foot inverus. It's very common in age 3 to 7. It persists in hemiplegia, but here is the caution. It converts into valgus in bilateral involvement. So if you have a diplegia or a quadri, eventually the foot will be in valgus. Therefore, you have to be very, very careful with trying to aggressively treat this condition. Do not address in under less than 8 years of age. And over 8 years, do not address in di or quadri unless and until the deformity is fixed. And you have to follow the equinus protocol in hemiplegics. That means give a lot of Botox, delay the surgery, and do undercorrect rather than overcorrect. And here is the scaled hemiplegic showing you equinovarus deformity. Now, hemiplegia over 8 years of age. Now, if you have a varus forefoot and you have a dynamic swing and you have a tibialis anterior overactivity on EMG, then you would do a split TA transfer or do a TA to third cuneiform. However, if you have a hindfoot deformity and you have a deformity in stance, you would do a split tibialis posterior transfer. Very often, I have realized that you do need to do column adjustments. So here is this kid who has undergone a medial column lengthening with an interposed graft and a shortening of the cuboid. And that gives you a good result. This is a kid just out of cast though. 2 words of caution: never lengthen the tibialis posterior and do not reroute the tibialis posterior through interosseous membrane, because this will give you a dorsiflexion contracture and that one will give you a horrific flat foot. Coming to planovalgus deformity. Now, planovalgus deformity is a spectrum disease. So therefore, its natural history is unpredictable in under 5s. But we know that as the kids get heavier, it worsens in adolescence. And there are many treatment alternatives, but none are clearly proven, and orthotic treatment is unproven. In fact, when you give an orthosis, it does what should not happen. Basically, an orthosis worn for an extended period of time weakens the muscle that is supposed to reverse the problem. So you have to reduce the orthotic time for these children. And surgery plan depends on the gross motor function level. If you have a high level ambulator, say 1, 2 or an early 3, you would preserve the joint and do a Mosca procedure. You would do a peronis brevis lengthening and a calcaneal lengthening. You may need additional procedures like tibial torsion correction and a wedge resection of the medial navicular cuneiform joint. Should your Mosca fail, then you have the option of taking it to a subtalar fusion. Ideally, try to preserve the joint in a high level ambulator. And remember, it's a part of the SEMLS, it's never done alone. Now, a low level ambulator, that means gross motor 4 and 5, you would straight away go for a fusion. You could do a medial column fusion, and depending upon the severity, for instance, if it's a severe deformity, you would do a talus to first metatarsal, as opposed to a mild deformity where you would do a navicular cuneiform fusion. And feet with poor control or dystonia, as you see in this, only fusion would be recommended, not an osteotomy. Now, bunions. Bunions in CP are of 2 varieties. You get a hallux valgus or you get a hallux flexus, right? Multifactorial causes. It's a movement disorder, a contracture, abnormal biomechanics, and muscle imbalance which cause the hallux valgus in cerebral palsy. Now, symptomatic bunions seen in about 2% of the cases as per literature. Topographically, it's very significant and gross motor is significant. So high-level ambulators will get hallux valgus, low-level ambulators will get a flexus. Dystonia will get a flexus. Hemiplegia will get a unilateral hallux valgus, and bilateral cases usually have bilateral hallux valgus. So it depends on what kind of CP you have in order to get the kind of deformity you get in the forefoot. Now, indications for surgery are pain, orthotic intolerance, pathological gait, or skin breakdown, but usually it's a part of SCMLS, and surgery is usually performed in adolescents. There are three kinds of surgeries really: soft tissue balancing and bunionectomy. Most people agree that the failure rate with this is very high, and though some people say, no, it's good, mostly we have the option of metatarsal osteotomy and soft tissue balancing, which preserves forefoot motion, especially with stairs and push-off. High recurrence rates have been reported in earlier literature, and this is one of our cases who had this as a part of SCMLS, a proximal metatarsal osteotomy, plate fixation, and soft tissue balancing. And she is a gross motor 4, and first MTP arthrodeses is the procedure of choice according to literature, and highest percentage of correction and patient satisfaction. So there was a review by Genter in 1998 who compared osteotomy versus fusion, and he says, well, the results are similar. These pictures are from the same kid whose foot you saw in the previous slide. So bilateral Moscas, hallux valgus correction, a Bernese at the top, and a lot of soft tissue work. Sarikaya in 2018 has proposed an algorithm for correction. Basically, when he says if it's moderate, do an osteotomy and soft tissue balancing, and if it is severe or there is dystonia, just do an MTP fusion. So the basic question, does skeletal surgery improve gait in CP? It depends on what literature you're really looking at. But I found this review, it's a systematic review by McKinley in 2012. He said that there is a large improvement in gait, but the gross motor function does not really improve. And the same thing is voiced by Roots et al., who says the gross motor function is unchanged or stable in 95%, which is also good, and improved by one level in 5%. And this is kind of our experience too. Whatever we may try, we do get some improvement in gait and walking cycles, but overall improvement is not that great. Thank you.